It's Friday, the 13th of February. Unlucky for some, but not for us, because this is the Hot Topics podcast. Welcome to the Hot Topics podcast from MB Medical with, as usual, me, Neal Tucker. Today, we've got 3 pieces of research that might change your clinical practice, or at the very least, might just make you think a bit. Not too much, you're not working right now, just enough. So what's the research this week? First, we have a paper in the New England Journal of Medicine on whether our patients need to continue with anticoagulation after ablation for AF. Second, a paper in JAMA examining both spinal manipulation and self-management for acute back pain. And finally, in the BJGP this month, a qualitative research paper on attitudes to early advanced care planning, which made me think about how important this conversation is and how it fits into general practice and beyond. As usual, NB News first. Quick hello to all the good GPs and other clinical staff of Southwest London that came to our face-to-face Hot Topics course on Wednesday. It was lovely to talk to you. Thanks to all of those of you who came and said hello, and especially those who chatted about the podcast. It was lovely to talk to you. If you want your area to commission MB to do your own course, whether online or face-to-face, even better, that's my preference, get in touch with the office. All the details are on the website. The downside of Wednesday was talking for 3 hours with laryngitis. Hasn't done me any favours for recording the podcast today, but we'll get through it together and I won't hold that against them. Remember the last episode where I was so smug about being so well for so long? Oh, that one's really coming back to bite me now. Meanwhile, we have a face-to-face course coming up, a face-to-face Hot Topics course on Friday, the 6th of March in central London. So if you need an update, check out the website for details. I won't be running that one. It's my fantastic colleague Simon Curtis, who set up NB 28 years ago. He'll be leading that one with some of my other fantastic colleagues. Or sign up to NB Plus to access all of our online courses, live and on demand, and much more as well. And to keep things sweet, we've got a Valentine's deal going on at the moment with £25 off an annual subscription until the 16th of February. So hopefully you're listening to this weekend, the weekend it goes out. Otherwise, you may be heartbroken, a rare cause of Takotsubo syndrome. Okay, on with the medicine then. So first paper, we've got antithrombotic therapy after successful catheter ablation for atrial fibrillation. Of course, keen listeners or readers of our MB blogs will know AF is a condition close to my heart, having had several runs of it a few years ago, each lasting between a day and 3 days until I gave up caffeine. I did see a cardiologist. They did offer an ablation, and I didn't fancy having that done at all. I don't want part of my heart being burnt out, much to their disappointment. And it's been just fine since going decaf. But I'm always curious to see what my likely future as an older person with AF has in store for me. One of the curious things about ablation is that even if it destroys the triggering aberrant pathway and you don't appear to get AF again, all the guidelines recommend continuing on anticoagulation afterwards forever. And I thought this was simply because rates of recurrence after ablation were pretty high. But this paper is looking at patients who've had at least a year since their last ablation, and at least on the simple tests that are available, doing Holter monitors for 24 hours or so, have demonstrated to be in continuing sinus rhythm. But as the paper explains, there is data, not necessarily the most robust or the highest quality, but it suggests that stroke risk remains elevated, subclinical recurrences of AF can still occur, and at least in the context of antiarrhythmic drugs, oral anticoagulation can reduce stroke risk even in patients who appear to be in sinus rhythm. Which is a bit of a bummer, having had a dangerous invasive procedure. Hopefully you might be less symptomatic, but I'm sure most people would love to be off the drugs too. Well, perhaps they can. Underpinning this paper is the concept that ablation has become progressively more effective, as has monitoring for further AF events, and together it might be possible to stop anticoagulation. The study then was a randomized trial which recruited almost 1,300 patients who had successful catheter ablation for AF at least 1 year prior and a CHADS-VAS score of 1 or more, 2 if they were women or had vascular disease. They were then randomly assigned to have low-dose aspirin or rivaroxaban 15 milligrams and were followed up for 3 years. They did a brain MRI at enrollment and at the end because they clearly have access to too many scanners. The primary outcome was a composite of stroke, systemic embolism, or new covert embolic stroke. That's why they wanted the MRI. The results essentially showed no significant difference between the two groups, either for the primary outcome or for major bleeding events, which they also examined. The really important bit was that events in both groups were extremely low. So 0.31 events per 100 patient years for the rivaroxaban group and 0.66 events per 100 patient years for aspirin. On paper, that looks like a big difference, but it's not statistically significant. And overall, that's less than a 1% risk of stroke in both groups. And this was a big surprise to the authors. They were expecting much higher rates, at least in the aspirin group. As they noted in the paper, a different trial of patients with AF and similar stroke risk, but who hadn't undergone ablation, their annual stroke risk was 3.7% for those taking aspirin and 1.6% in those who are on a DOAC, which is A, much higher, and B, a much bigger difference between the two. All of this sounds rather positive for the concept of ablation. Glad I didn't do it 10 years ago, but if my AF recurs in the future, I may well consider it, given the very positive outcomes. It's not just about stopping medication. Now it's about risk reduction in itself. Of course, there's always caveats. The key one here is that average CHAD-VAS score was just 2, and the average age was young at 66 years old. The editorial points out that recent observational data suggests that patients with a CHADS-VAS score which is higher, so 3 or more, might still benefit from continued anticoagulation. The paper also, of course, used aspirin as a comparator rather than placebo, which would sound preferable. But aspirin has negligible effect on stroke risk, at least in lower risk patients. And taking aspirin in itself is not without risk, so could be associated with more harm than benefit in that lower risk group. So the story isn't truly complete, but it has got a little bit richer. Should you and I be stopping our patients' anticoagulation after ablation? Hell no! Not least because the patients in this study have had at least 3 24 or 48-hour Holter monitor tests to exclude AF, which you and I probably can't do. When your patient says, "Oh, don't worry, I've got my Apple Watch on, that'll tell me exactly what's going on," don't buy it. But don't be surprised if, in the near future, you start getting letters from cardiology saying it is okay to stop that DOAC. All right, on to our second paper, and this is on back pain, such a common problem. It can feel like our options are pretty limited in general practice. National guidance is to get people to fill in a questionnaire, the Start Back tool, which is often met with much bemusement, I find. I said my back hurt and the doc got me to fill in a form, and might well explain why patients often go off and explore other modes of help, which is how I ended up getting that dreaded letter a few weeks ago from one of my patients' chiropractors saying, despite spinal manipulation on several occasions over 2 to 3 weeks, there has been no obvious improvement, therefore an MRI is indicated. Is it? Please could you organise? Oh dear. Well, nothing's going to piss you off as much as one of those letters, not even a lack of custard creams at the coffee break. I've got nothing against other practitioners trying physical treatments to help our patients. I genuinely hope that it actually works for them. But please don't get their hopes up about tests that may or may not be appropriate and we may or may not have access to, and even if we do, may or may take longer than the average human lifespan to obtain, unless you pay for it, like you have been with your chiropractor. But given the guidelines suggest analgesics don't often work, are we out of options? Is there anything that actually might help our patients? So what I love about this paper is, first, it aims to answer the question about whether spinal manipulation actually works. And second, it asks whether self-supported management could be useful. Third, whether the two together might be advantageous. And fourth, how do these compare to guideline-based medical care, at least American guideline-based medical care, which in the context of this study involved at least two 15 to 30-minute consultations with medications as the first line. So they recruited a large number of patients for one of these studies, 200 to 300 patients in each of those four groups, all adults with acute or subacute low back pain at moderate to high risk of chronicity based on the START back tool. Yes, even the Americans are using the START back tool. The intervention period was 8 weeks. Spinal manipulation was conducted by physical therapists or chiropractors during 2 or more 15 to 20 minute sessions. Clinician-supported self-management actually involved a lot of clinician support, and it feels a bit like less self-management, because they had 4 to 8 60-minute one-to-one sessions with various different self-management elements. And I had assumed that would be something like go do some yoga, which is what I often tell my patients. I don't know why do they go and seek other forms of help? I just don't know. But actually it included pain education, physical exercises, cognitive behavioral and social strategies. So quite involved. That actually mirrors the same kind of thing that you and I would be referring to if we had someone who scored high on that START back tool, if we were going to explore that more physiotherapy-led biopsychosocial approach. The primary outcome was a low back disability score and a weekly pain intensity score, which they measured over the course of the 1 year of the study. So, 1,000 patients, what did it show? Firstly, spinal manipulation showed no significant difference for either outcome. I'm almost a little sad about that, but not particularly surprised, having had years of patients coming in going, I've been trying this for ages and it still's not got any better. The clinician-supported biopsychosocial self-management program did show statistically significant improvements in disability, which is great news. Not in pain scores, which is less great news. And slightly disappointingly, the level of improvement they saw was described as small. When the authors are describing their improvements as small, you know it's not going to be that great. What can we take away from this? Well, low back pain can be a miserable problem for our patients and a difficult thing to treat. Existing UK guidelines incorporating the START back tool currently appear to be the best option, with referral to a physio team for more extensive input in patients at higher risk of chronicity, and this data supports that approach. Adding spinal manipulation to this or doing it by itself, unfortunately, doesn't seem to help. It also suggests that failure of improvement with private physical therapy isn't necessarily an indication for immediate MRI of your back. But it would be very reasonable to go and see your GP to have a chat about your back pain. Just don't be surprised if we get you to fill in a questionnaire first. Finally, this BJGP paper titled Attitudes to Earlier Advanced Care Planning, a qualitative interview study in general practice. I know what you're thinking, Neil. You're thinking, is this really that interesting? Because advanced care planning is not a hugely interesting thing to do in practice, let's be honest. The aim of the study was to explore what people living with long-term non-cancer conditions understood about advanced care planning and their thoughts about how these discussions could or should be undertaken. The reality is that most advanced care planning happens late when patients are already unwell or very frail. And is this really the best time to be having these discussions? Now, this is not a huge study. It recruited 21 patients between the ages of 61 and 91. But that's the nature of qualitative work, and you can still get really powerful information out of close discussion with individuals in this way, in a way that it's hard to with a time limits on our normal consultations. Firstly, the authors asked what people understood by advanced care planning, and unsurprisingly, most didn't recognise the term at all. But when asked about planning ahead, generally, people could give a much more detailed answer. The authors then discussed 3 aspects of advanced care planning in more detail: proactive planning, preparing for change, and discussing end of life. Unsurprisingly, I think, people were generally positive about discussing all of this. It becomes clear that most people are thinking about these things, framed around their own personal experiences, including their health issues. But until they are asked, they tend not to share these thoughts about the future. The interviews suggest that particularly for end-of-life discussions, doing this early on when people are well actually makes it an easier conversation for everyone. And it's a conversation that they valued, as long as they had the option to revisit it at a later date, acknowledging, of course, that things change, what people want might change, and so advanced care plans may have to change as well. The really interesting bit was how patients felt advanced care planning could be better incorporated into primary care. There was a strong desire to normalise the process, perhaps make it part of their annual health reviews. Given they all had long-term conditions and some had multi-morbidity, we're obviously going to be seeing them on at least a semi-regular basis. So there are opportunities to be able to do this. Who should have that discussion is a slightly different issue. Many felt that a nurse would be the best option. Often people have easier rapport, better rapport with the nurses. Maybe they feel they have more time. Some with more complex health problems felt that a doctor may be preferable. People generally felt they wanted more information and that the issue should be discussed more widely. The authors conclude that advanced care planning may be well received and could be discussed earlier with adults living with long-term conditions before onset of advanced illness or severe frailty. I think what fascinates me about this study is just why people, and I'm not sure this is unique to the UK, but why people don't like talking about the future and they don't like talking about death. We definitely don't like talking about dying. The debate around assisted dying has sparked some discussion, but really that's a very small niche. But of course, everybody dies eventually, except perhaps Elon Musk, who I could see having his brain in some jar hooked up to some wires in perpetuity, still pumping out crazy comments on Twitter in 100 years' time. The rest of us, we're all going to die. So why don't we feel more comfortable talking about it? And I think that we need to think bigger than simply trying to incorporate earlier advanced care planning into general practice. We need to demedicalize it, not just make it more medicalized. Demedicalize it, make it normal to chat about these things with your family, your friends. Have a simple, standardized national document that people could fill in, detailing what they might want regarding life and death as you get older. And then you could send that into your practice so that we all know as well. But make this a wider conversation. Really, I think what we need is a national campaign to try and shift opinion at a population level, making it the norm to talk about these things with each other. Who can do that and or how to do that is not immediately obvious, and perhaps that's the problem. But I've only really been thinking about this for the length of a podcast, and we've got lots of really smart listeners out there. I doubt together this idea is beyond us. Talking about dying could seem like a bit of a downer of a way to finish, but I see lots of positives in this research and in this idea going forwards. Anyway, that's it for the medicine today. Thank you so much for listening to the podcast. As always, remember you can get in touch if you want. You can email at hottopics@nbmedical.com. Find us on Facebook and X and even YouTube, I think, these days. Maybe one day we should do a live stream. That seems to be in vogue these days, doesn't it? I'd be terrible at it and have to put trousers on, probably. We'll be back in 4 weeks. Don't forget the MB Plus deal and that London face-to-face date. Look after yourselves. Take care. Bye-bye.